أعوذ بالله من الشيطان الرجيم بسم الله Assalamu alaikum and good afternoon to everybody. This is today we will discuss the acute syndrome management. We discussed in our last talk pathophysiology related to acute syndrome, and today we will discuss the management of acute syndrome. In our previous talk, we described that there are various presentations of this clinical disease. One is the acute presentation, there is chronic presentation, there is chronic stabilization, and among the acute coronary syndrome, we discussed there are different disease name, institution, acute and disease these are the acute presentations. Now we will discuss the management of the acute coronary syndrome. Where most of the patients present acutely and the mortality is very high. So learning the acute coronary syndrome, its management is very vital for every student, everybody who is practicing in the field of pathology or even in the field of medicine. So management is we can divide it is a focus management, and there is a support and definitive management, and there is some compelling management. We will discuss these terms later on during our presentations. So just to recap regarding the mechanism of acute coronary syndrome, we know that there is a coronary vessel and there is a atherosclerotic plaque over there, and you know that the process starts from the plaque fissuring and plaque erosion, and whenever there is plaque fissuring and erosion, there is exposure of the subentymal material to the blood, circulating blood cells, and which they then become activated, platelets become activated, and later on aggregated and form platelet plug. And when platelet plug is formed, and there is again activation of the coagulation cascade as well, and there is generation of thrombin and ultimately fibrin, and platelet bound heart clot is produced in the vessel, which obstructs the blood flow. And due to this acute diminution in the supply of the myocardium, there is acute reflective response in the coronary artery as well, which also aids in the reduction of coronary blood flow. So you see, the whole mechanism is started with the plaque fissuring, plaque erosion, and activation of the platelets, and activation of the coagulation cascade, and formation of the thrombus. So these things we should remind that this process, when you understand the process which is occurring during patient presentation, because everything is occurring in the coronary artery and you are managing a patient. So patient present with some adjustment, and there is a formation of the platelet plugs and the activation of the coagulation cascade in the coronary artery, which blocks the vessel. So when you know this pathophysiology, then you will be able to intervene during this process of pathophysiology, and you will somehow make patients survive, or your efforts will bear fruit for minimizing the myocardial ischemia. So this is how the coagulation cascade starts. So whenever there is a exposure of the tissue factor to the endothelial material, there is activation of the factor 7A, which activates factor 10, and factor 10 then hits on the prothrombin, and thrombin is generated, and finally thrombin attracts the fibrin, and there is formation of the heart clot. So This is the actually cycle of the events that occur, the, that take place inside the coronary artery. So meanwhile, you see the upper part of this figure show there is a presentation, means patient present with the ischemic discomfort. He has got chest pain, chest discomfort, shortness of breath, or any angina equivalent. So this is the patient presentation, and you are working for this patient and making diagnosis and treating the patient. While you are dealing with the patient, your diagnosis when patient present with the ischemic pain. So this your working diagnosis will be acute coronary syndrome. Means acute coronary syndrome is actually the initial diagnosis when you make initial minutes in initial hours of patient presentation, and you think this patient has got chest pain that is most likely due to ischemia. Depending upon the patient's age and risk factors, you decide that this is a pain that is related with the ischemia and that is most probably related with the coronary arteries. So what happens when you are making the diagnosis and treating the patient or approaching the patient, taking history, these things are happening in the coronary artery at that time. Means there is formation of platelet clot, formation of platelet. So depending upon how much this clot obstructs the vessel, sometimes this can obstruct the whole vessel also this time. Sometimes this can obstruct partial vessel lumen. So when there is a partial uh, blockage of the coronary artery, then patient labeled as having non-ST myocardial infarction and non-ST elevation in their ECG. When there is a complete occlusion of the coronary artery, the ECG shows the ST elevation. So at this time, you have got the first ECG available with you, and ECG will tell you indirectly that with this patient has got um, complete occlusion of the coronary artery, or this patient has got incomplete occlusion of the coronary artery. So whenever there is ST elevation in the ECG, you might think to your mind that this patient has probably complete occlusion of the coronary artery. And ultimately, when there is complete occlusion of the coronary artery, there will be dense myocardial infarction, the whole thickness of the myocardium will be involved, and the whole of the thickness of the myocardium will be necrosed. And when there is partial obstruction, means there will be some ischemia, there will be some necrosis, there will be some surviving cells over there. So patient will have not full thickness myocardial infarction, but we can call that this patient has submyocardial infarction. Previously, these were the classifications of myocardial infarction, submyocardial infarction, and whole thickness of the infarction. And ECG wise, they were diagnosed as having a clear infarction, non-clear infarction. So whenever there is a clear in the ECG, most probably that means that the most of the myocardium is dead. So actually, this is the primary ECG which tells you that what is happening in the coronary artery. From here, the treatment will start in both groups. As we talked in our last lecture, that estimation MI patient will be managed on one line, and the patient with ECG don't show any ST elevation will be managed on the other line. So ST elevations group, the patient who present the ST elevation on ECG, you think this is a complete apnea of the coronary artery. Now you have to open this coronary artery. So means the every effort will be made to open this coronary artery that is completely occupied by thrombus. So we have got two means to open this. One is the pharmacotherapy and other is the intervention. Pharmacotherapy means when there is a thrombin, when there is a fibrin over there, complete occlusion, there is no district flow behind the blockage, so district blockage. So you have to thrombolize with thrombolytic agent. One solution is there, you do the coronary pharmacologically by infusing some thrombolytic or thrombolytic agent. That is the one part of the treatment of patient with ST elevation. And second is the if you want to make patient survive because the thrombolytic therapy can open a coronary artery in certain group, certain percentage of cases, say about 30% to 60%, depending upon which thrombolytic therapy you are using. But if you go inside the coronary artery by catheter-based treatment, you suck out whole thrombus and you restore the coronary blood flow. This is not the coronary intervention. Intervention means you are doing something inside the coronary vessel. You want to suck this thrombus through a catheter and you open the coronary artery. So this is not the coronary intervention. So there are two ways to open the complete coronary artery. One is the pharmacological method by lytic agent, and second is the intervention method known as the coronary intervention (PCI). Most commonly, you have the term PCI. Sorry. So those patients who present initially with the chest pain and their ECG shows no ST elevation, this group is known as having no ST elevation. We call this as non-ST patients. So after a few hours, 6 hours, 12 hours of your working diagnosis, you start doing some test on the patient and especially biomarkers. If you say biomarkers are elevated, definitely in patient who have a stimulation MI and in those group of the patients who have non-stimulation MI. So biochemical markers are very important in making the diagnosis whether the patient has got infection or not. So you see, all things started with the clock, Korean clock, fissuring, repeating, and aggregation of and activation of the platelets, and the generation of the thrombin, and formation of the fibrin clot. So this is the whole scenario that starts with the erosion of the clot. So now your treatment will focus on this platelets and coagulation cascade, and definitely the endothelium itself. So time is very important because in case of coronary acute coronary syndrome, every minute and every second is very much important. Otherwise, you might be dead if you do not restore the blood supply to the skin of myocardium. So this is very important. You should not slip time from your hands. So you have to admit this patient where these are being treated with acute coronary syndrome. So this is the better place to keep these patients and treated there. You should maintain their IV line and you should monitor for any arrhythmias. You should take the ECG within 5 minutes. You quickly examine the patient and take history. And history, especially history, will not establish the diagnosis, but this will tell you certain criteria for thrombolysis. Are there is any contraindication to thrombolysis? Is there any complication of the started in the patient? So this history in the MNC must be focused. Uh, so otherwise, this is not history and examinations are not meant here to diagnose the acute coronary syndrome because diagnosis depends upon your collection of your patient's symptoms, his risk factors, and ECG. Then you make the diagnosis, and then you start treatment until the labs are available because you should not wait for the biomarkers available with you. Then you start treatment. When you start treatment, when patient arrives and the emergency department are to see a coronary unit. So, you established criteria for perfusion therapy. You established criteria for the PCI by taking history. So you see, platelets because these are the primary culprits which involve in making occlusion of the coronary. First step is the after plaque rupture. The first event that occurs inside the coronary vessel is the activation and aggregation of the platelets. More and more platelets will aggregate, and more they will be uh, activated, and after platelets are activated, then they produce more receptors for binding of different things. More platelets will be binding on the surface with the other cells, and there are some molecules that are produced and they are expressed on the walls of these platelets, and certain receptors are produced after activation of the platelets. These are expressed on the wall of the platelets, and so uh, platelets is your main focus of treatment. So you uh, start with the antiplatelets because this is the mainstay of treatment during initial minutes and hours. So platelets can be blocked as we discussed. There is aggregation of the platelets, there is activation of the platelets, and then for expression of certain molecules or receptors on the surface of the platelets. So these are three pathways that you would block with the treatment. So one pathway is the that help in the aggregation of the platelets, thromboxane related pathway. So this is blocked by the aspirin. So aspirin blocks this aggregation part of the platelets, and then sorry, then activation the cyclic AMP and the formation of the ATP. These are the processes which involve activation of the platelets. So now platelets are blocked with the aspirin. This pathway is blocked by the aspirin, and the cyclic MP pathway will be blocked by the ADP. This will be blocked by the clopidogrel and declopidogrel. Declopidogrel is not nowadays not used because there are some side effects. The clopidogrel is the main drug that blocks this pathway. The cyclic AMP ADP pathway. This is blocked by the clopidogrel, and then the receptor pathway where the fibrin binds. So the other pathway, third pathway, that is the GP2B3A receptors are blocked. These are the fibrinogen receptors where the fibrin binds. So this pathway is blocked by the GP2B3 inhibitors. So there are various drugs that block the GP2B3 inhibitors. So means we have got three antiplatelet blocking mechanisms. One is the thromboxane pathway blocked by the aspirin, cyclic AMP pathway blocked by the clopidogrel, and the GP2B3A pathway blocked by the uh, GP2 3 inhibitors. So you have to block these pathways. So initially when patient interest in this issue or emergency, you suspect this is the acute coronary syndrome. So you immediately you give aspirin 300 milligram to the patient, and 300 milligram of clopidogrel to this patient. While the GP2 3B inhibitors are reserved for those patients who are supposed to go for intervention. Otherwise, in CCU and emergency department, you have to load patient with these two antiplatelet agents. One is the aspirin, and other is the clopidogrel. This is the drugs which can save the aspirin can save the 30% of the patient who present with the acute coronary syndrome. So this is the very mortal reducing drug during initial minutes. So you administer aspirin and clopidogrel in a patient who present with the acute coronary syndrome. So this pathway will be blocked. And then comes the role of anticoagulation. You see, when platelets are activated and aggregated, they release certain factors that attack that start with the uh, initialization of the coagulation cascade and formation of the thrombone and then the fetal blood. So that means that you would block this pathway as well. So there are various drugs that can block this coagulation cascade at different levels. So you can have a heparin, high molecular weight heparin, or you can have a low molecular weight heparin. These are 83 dependent drugs that block the activation of the factor 10. And there are certain drugs that can block the direct thrombin, like heroin and heroin. These are the anti-thrombins directly inhibit the therapy thrombin itself. So uh, this coagulation cascade is blocked by the anticoagulation mechanisms. Usually, commonly, we give low molecular weight heparin to the patient present with the acute coronary syndrome. So So this pathway is blocked means when you block the platelets and you block the coagulation cascade, your aim is to minimize the propagation of the thrombin, platelet plug or thrombin that is formed. So your ultimate aim is to restore the distal blood flow to the myocardium whenever there is formation of thrombus inside the coronary vessel. So this is the what we discussed just that heparin, clobazam, warfarin, and ribulazurban can be given in a patient with the acute coronary syndrome. So your ultimate uh, aim is the restoration of the myocardial perfusion through restoration of the coronary blood flow. We discussed that we can do with the this by the inhibiting the platelets so that there will be no further aggregation of the platelets. There should be no further activation of the platelets, and there should be no further binding of blood to the platelets, and there should be no further formation of the thrombus by formation of thrombin. So these are the different drugs that are used to inhibit the further propagation of the clot inside the coronary artery. So actually your aim is to restore the blood flow inside the coronary artery. So we discussed that whenever there is a blockage of the coronary artery, you got three means by which you can restore the blood flow. One is the pharmacological treatment, uh, that is the thrombolysis, and percutaneous coronary intervention, and coronary artery bypass grafting. So these are the different means by which you can open the artery. So this is a result for those patients who have complete obstruction of the coronary blood flow. Means antiplatelet will be given and anticoagulation will be given to this patient. But the third thing is the ultimate your goal is if there's no uh, proper results are found in the patient, then you give thrombolysis. Those patients who present with the ST elevation. Now we are talking about the ST elevation. ST elevation patients are managed with the apart from the antiplatelets and anticoagulation, they are managed with the either thrombolysis because there is complete occlusion of the coronary, you have to use thrombolysis, or you have to mechanically dislodge this clot from the coronary artery by performing the coronary intervention. And cabbage in certain patients in which all mechanisms fail and there is no or there are some complications related to myocardial infarction, then some patients can go cabbage to revascularize the arteries and to increase the myocardial flow. So there are certain targets in patients with EST vision MI. So uh, because if you timely you manage the patient, you restore the coronary blood flow, then patient's life and myocardium will be saved. If you delay, there is no timely patient involvement and treatment, then definitely the survival rate will be less and there will be no effective fruit of your management. So time is very important. So if you decide in a patient who present with chest pain, have got ST vision on the ECG, and those patients who are not going for cardiac catheterization, your choice is the fibrinolytic therapy. So this fibrinolytic therapy must be administered within 30 minutes of presentation. So because these 30 minutes are very important. After 30 minutes, myocardial cells will start necrotizing and they will be dead myocardium. There is no benefit of treating dead myocardium. So for fibrinolytic therapy, no to needle time when patients arrives at a facility, cardiac facility, and administration of the thrombolytic therapy. This is known as the door to needle time for fibrinolytic therapy. This is less than 30 minutes. Means in these 30 minutes, initial 30 minutes, you have to take history, you have to take find any contraindication of fibrinolytic therapy, you have to take ECG of this patient, and then you start immediately. If there is no contraindication to thrombolytic therapy, then you administer this thrombolytic therapy to the patient. Or if a patient of ST elevation chest pain and ST elevation MI arrives in a center, cardiac center, where the cardiac catheterization facility is available, hence for an angiography, angioplasty facility, cardiac cath lab is available, and cardiac cath lab because the catheter-based treatment, the mechanical displacement of the catheter can be performed in a cardiac catheterization laboratory. So whenever you find these patients in a center where catheterization laboratory is available, then these patients should be sent for angioplasty rather than by the thrombolytic therapy, because we already talked that thrombolysis can restore blood in 30 to 60% of the patient, but the catheter-based treatment of section of thrombus or estimation in patients who are managed with catheter base, the restoration of the blood flow is more than 90%. Means chances of opening coronary artery are more than 90%. So wherever the cath lab is available in a center, patient with EST elevation must be referred for the coronary intervention rather than the thrombolytic therapy. Where there is no facility of thrombolytic cardiac cath lab, these patients must be managed with the thrombolytic therapy. And here the for thrombolytic time is the load needle time is 30 minutes. But in case when your target is to send the patient for angioplasty, then here the dot balloon time is less than 90 minutes. Because you see the activation of the cath lab team and its personnel shifting a patient from the emergency or coronary unit to the cath lab takes some time. So the patient should reach the coronary cath lab, and you insert the balloon catheter inside the coronary artery, and you inflate the balloon in the coronary artery. So the time of presentation to the inflation of the balloon in the coronary artery, this target must be 90 minutes. So if you do it in less and less time, the more and more myocardium will be saved, and patient will be having more benefit of treating than timely. Otherwise, there will be no benefit of treating patient if you delay any option. If there is any delay in the cardiac catheter team, suppose catheter is busy doing angioplasty or some other procedures, you cannot see the patient with coronary artery, there is a delay of 2 3 hours, then it is better to do thrombolysis rather than the angioplasty. So this is very important. So this time you must learn and you treating a patient with the acute coronary syndrome. These are the different fibrinolytic therapy that are available. The streptokinase, LTPase, and tenofovir. The most commonly used in our setup and our country is the streptokinase, and other is the LTPase. Other are rarely used; they are not available here. But the most the commonly used are the streptokinase and LTPase. They are not so much costly. They can be every government hospital or any private hospital. So they are very easily available and they can be given to patient who present with the ST lesion or cardiac problem. But before I told you that you concentrate during the taking ST, that patient should not have any contraindication for thrombolytic therapy because in ST you focus on these things. There are certain patients who are having absolute contraindication for the thrombolytic therapy. Means they are not suitable candidates for thrombolytic therapy. So these are the certain factors which list of certain factors. Number one is the any prior intracranial hemorrhage that is proven by the CT scan and MRI. This is the absolute contraindication for thrombolytic therapy. Atrioventricular malformation that is diagnosed previously is complete contradiction. Any malignant intracranial neoplasm or any stroke in less than 3 months duration is a contraindication for the thermolytic therapy. Any suspected aortic dissection, this is the contraindication for thermolytic therapy. Active bleeding or bleeding diathesis in a patient who got certain bleeding disorders. Uh, these patients are contraindicated for use of thermolytic therapy. Any significant closed head or facial traumas of less than 3 month duration. These patients are again having absolute contraindication for the thrombolytic therapy. And there are certain relative contraindications to thrombolytic therapy. Means you can give thrombolytic therapy, but there are certain limitations. So there is any history of chronic severe poorly uncontrolled hypertension. Uh, and those patients who have got especially blood pressure at presentation is more than 108 systolic and has to more than 10. You can treat this blood pressure, then you can do the therapy. History of any primary prior ischemic stroke or more than 3 months, dementia or non-intracranial pathology. This is the relative contraindication. Traumatic or prolonged CPR for more than 10 minutes of major surgery less than 3 weeks. This is the relative contraindication. Recent internal bleeding. This is the relative contraindication with therapy. Any non-compressible vascular punctures. Suppose a patient has got any procedure of vessel that cannot be compressed. So these are the patients who do not go for therapy. Any prior exposure to streptokinase or more than 5 days or allergic to any streptokinase. And pregnancy is relative indication. Active public ulcer disease is relative indication. And current use of anticoagulation, higher the INR, higher the risk of bleeding. When a patient got increased INR levels, the risk of bleeding is more. If any patient with INR less than 2, it does not pose any problem, but any patient with an INR more than 5, definitely there will be the risk of hemorrhage that can be internal, intracranial, from anywhere. You see, we discussed that there is certain treatment in our initial slide that the treatment is focused and additive and compulsive. I tell you there is some compelling indication for certain things. So focus means you focus that patient because whole mechanism start with the activation of the and aggregation of the platelets and activation of the platelets and the activation of the coagulation cascade and then formation of thrombus means this is your primary focus and you have to primarily block the antiplatelets, you have to block the coagulation system and this is your primary focus treatment and then the whether this patient is called ST MI or non-ST. For those who present with the ST MI, must go for the thermolytic therapy or primary percutaneous intervention depending on the availability of the cath lab and having any contraindications or indication for the thermolytic therapy. So this These were the focus treatment. Other than the treatment that can be, you can say this additive or supportive treatment. Suppose a patient who has got increased heart rate, increased heart rate will consume more energy and produce more ischemia. You have to give beta blockers to these patients. Sometimes nitrate will help in restoring the patient's ischemia by decreasing the preload from the heart. Sometimes SE inhibitors are used, especially in those patients who have got really dysfunction or in those patients who have got already hypertension. So you S inhibitor in these patients is statin because you see the endothelium, disease endothelium, which was atherosclerosis and clot ruptured means endothelium is not healthy. So the statins are the drugs which stabilize the endothelium. They lower the cholesterol levels and they also maintain the normal function of the endothelium as well. So again, this is a part of focus treatment. Means you are thinking that the process started from the atherosclerosis, so drugs they block the slow the process of atherosclerosis, or at least they maintain the normal endothelial function. These are the statins. They must be given every patient who has ischemic disease and naked coronary syndrome, antiplatelets, and anticoagulations. And definitely a patient who is diabetic, they will need the specific treatment for the diabetes mellitus, and definitely you have to care this patient, general care of this patient regarding his diet. So usually in initial hours of myocardial infarction, the diet is usually liquids or semi-solids given, and bowel. Patient should not be constipated because this will extend to produce more ischemia. His sleep must be normal, and earlier mobilization when patient become symptom free and there is no complication, patient should be mobilized early from his bed, and so that there should be no further complication related to bed ridden patients. So these are the general care of a patient which is offered in CCU and in the ward. So in last couple of slides, we discussed the management of the established MI. Means acute kidney syndrome, part of acute kidney syndrome, they present an ECG with their initial ECG with the estimation MI. We treat them with the thrombolytic therapy or PCI. In addition, definitely from the emergency, from the arrival of the patient, we started platelets and anticoagulation, and then definitely whether patient will undergo primary coronary or patient will go reperfusion therapy like thrombolysis. So now, what to do with the patient who have unstable angina or non-ST elevation? These are those patients who present with the acute chest pain. But their initial ECG can be normal. Their initial ECG can show ST depression. Their initial ECG can show T-wave inversion, but there will be no ST elevation in this group of patients. Now, how we say this unstable angina and non-ST elevation MI? MI means myocardial infarction. Myocardial infarction is the necrosis of the myocardium. Until unless there is no any evidence of necrosis, you cannot label the patient as having a myocardial infarction. Because by definition, infarction means necrosis of the myocardial cells, and their necrosis has to be established. And the necrosis is established by release of the cardiac markers in the blood. Means a patient who present with the chest pain and ECG do not show ST elevation. Now, this patient is having unstable angina, and suppose you send the markers of these patients, certain patient will have increased blood markers of myocardial necrosis, means their LDH and troponins will be normally increased in the blood. So these group of the patient will be labeled as having non-ST elevation myocardial infarction, because now you have got indirect evidence of myocardial infarction, that is presence of myocardial markers in the bloodstream. So means these group of the patient who present with the no ST elevation in the ECG, they present the chest pain, their enzyme become positive. Now you label these patients as having non-ST elevation myocardial infarction. And still those patients who again present with the same chest pain, risk factors, ACG initial ACG is showing no ST elevation, but their markers are repeatedly now. Means you do the cardiac markers after initially, and then after 6 or 12 hours, and there will be no increase or there's no detectable markers of myocardial necrosis, means especially troponins are negative and other cardiac enzymes are negative. That means this patient is definitely having acute coronary syndrome and having unstable angina, but you cannot label this patient having myocardial infarction. Because for myocardial infarction, you have you have some evidence, and evidence is through the cardiac markers that are the cardiac enzymes. So those patients who present with the chest pain and no ST elevation have positive markers. These are labeled as non-ST elevation MI, and the patients who present with chest pain, no ST elevation in the ECG, but have normal myocardial markers, that these patients are labeled as the unstable angina patients. But you see, we divided initially patient with the non-STMI and STMI. These are two groups. Unstable angina and non-STMI are treated on the same line. ST-MI are treated on the other line. Because for ST-MI, you have two options: thrombolysis and PCI, plus additive treatment, like I told you. And in these group of patients who present with the initial no distribution in ECG, but they were either raised enzymes or they are no raised enzymes, these are labeled and treated on the same line. So you treat this patient with the aspirin, you treat this patient with the antiplatelets, you treat this patient with the other suppose anti-diabetic, anti-hypertensive, beta blockers. Every requirement you fulfill this patient. But these patients sometimes can go for cardiac catheterization. And there are certain indications for these patients. Initially, these patients are managed with pharmacological measures. Means you have to give aspirin, antiplatelets, clopidogrel, anticoagulation happens in these patients. But some of these patients will require cardiac catheterization. So, what are those patients who require cardiac catheterization? Then patient must be taken to cardiac catheter for coronary angioplasty. These are those patients who, on optimum medical treatment, have recurrent angina and MI death. So, because if you do not treat this patient, then the patient will have recurrent angina, ultimately MI and death. So, recurrent angina patients on medical treatment must be managed. Apart from medical treatment, must be managed with cardiac catheterism. Otherwise, they will produce MI and they will ultimately will lead to death. So, so in those patients who have recurrent angina, despite this all treatment, you have to take this patient for coronary catheterization, because here you have to find the anatomy of the coronary vessels, what is the problem with the patient, and what definite or appropriate strategy you will apply this patient, because this is the group of the patient that carries a very high mortality, and this very difficulty. And usually, in patient who present with the ST vision MI, usually they have got single vessel disease, as compared to those patients who have unstable angina and non-restitution MI. After catheterization, we have found that these patients usually come with, when do the angiography, you will see there will be more coronary vessel involved. Means the more than single vessel. Patient may have a single vessel, but often they have a two vessel disease or three vessel disease. So, what are the patients who require PCI in these patients of unstable angina and non-respiration group? So, any patient who has got previous history of coronary intervention, any patient who has got history of KBA, and patient who have got recurrent angina, patient who have got symptoms of cardiac failure, any patient who have got depressive function, any patient who have got malignant ventricular arrhythmias that are not responding to conventional medical treatment, and recurrent angina, we talked about that, and any large defect on the perfume, and sometimes patients who have got significant valvular disease along with the ischemic disease. These are the patients who require cardiac catheterization. Because cardiac catheterization is basically the treatment for the distribution of the group, but these are the patients who ultimately require cardiac catheterization. And whether a patient should go for cardiac catheterization, patient should go for coronary artery bypass grafting or coronary angioplasty. Depends upon certain other factors like age and comorbidities, severity of the coronary disease, prior revascularization procedures, technical feasibility, whether you can do angioplasty or not, durability of the percutaneous revascularization. These are the factors. They on which you decide whether the patient should go for KPage or PCI. So KPage is preferred in those patients who have got diabetes mellitus, or patient who have got left ventricular dysfunction, LVD means left ventricular dysfunction, or patient who have got significant burden of coronary disease, means they've got left main disease, and those who have got T-vessel disease, and those patients who have got two-vessel disease with involvement of the left anterior descending artery, and especially proximal part of the left anterior descending artery, or patient who have got two-vessel disease plus LV dysfunction, or any ischemia on stress testing. So these are the patients who are preferably managed with the bypass rather than PCI. These are certain names given to the angioplasty. One is the Prof, means percutaneous or balloon angioplasty. This is the term you should must know because you can find somewhere written over there. Prof means percutaneous or balloon angioplasty. Initially, when angioplasty came as the treatment of coronary intervention, then only balloon was to be inflated inside the coronary artery, and nothing, no other procedures being done inside the coronary artery. So there is only inflation of the balloon inside the coronary artery, and then there was restoration of the blood flow to the dead distal myocardium. So this was the result for nowadays result for those patients who only go for the balloon inflation. So primary angioplasty means when patient will be present with the excavation of infarction and you do coronary intervention. Here coronary intervention means you do the angioplasty with the different equipments. Here you got some apart from the balloon, you've got some stent. You place the stent across the synovial. So here we call it as a coronary intervention because you are doing more than the only balloon inflation. So there are different procedures that are being done during the coronary angioplasty inside the coronary artery. So primary angioplasty is actually the primary coronary intervention. Angioplasty is trying the result for those patients who initially go for the thrombolytic therapy, but due to failure of the collaborative therapy patient not have any relief in the chest pain or there is no resolution of the CST segmental region, then you do the rescue angioplasty. Means after failure of collaborative therapy, to do the angioplasty, this is the rescue angioplasty. And one term was used as a facilitated angioplasty, in which you initially manage patient with the collaborative therapy, and then you go for the coronary angioplasty. Nowadays, this is a resident angioplasty, do not have a separate data, so usually it is not the commonly used procedure. So for primary angioplasty means estimation MI, and you do the angioplasty, this is not a intervention. MI means you are performing for the estimation MI point function. So it's very important. Terms that you memorize, you can come across your practical life. This is how the catheters look like when you go inside the corner. This was my first angioplasty I did in 2007 in a patient who was in of Khaskheli. You can see there's a catheter inside the coronary. There are some wire going across, stent going across the coronary artery, and then balloon is being inflated, the stent is being applied in the coronary vessel. So this is the procedure of the primary coronary angioplasty that is done for the treatment of patient with the infection, myobronchial infection. So I stop here and we will cover the acute management of the acute coronary syndrome and few lines regarding the chronic stable angina. Uh, because you know the ischemic heart disease is the same. Chronic stable angina, the term is related with the chronicity of the disease, means those patients who do not have serious symptoms and those patients who have got no recent change in their symptoms and there is no worsening angina. These patients are known as patients who are suffering from chronic stable angina. So these are patients who are managed with the beta blockers, nitrates, aspirin, statin, clopidogrel, and these are not acutely treated anticoagulation and loading of the both antiplatelet agents. These patients chronic stable angina usually managed medically, and when their symptoms worsen and they are not managed with the medical treatment, then these go again, patient go for the angioplasty bypass. So otherwise, the treatment regarding the chronic stable angina remains same, apart from the acute presentation of disease. So thank you very much. If you have got any question, you have 5 minutes for putting any question. So I'm here to respond to you. Any question?